Suma Ganesh is going to speak to us on role of atropine eye drops in management of myopia. Dr. Suma Ganesh.
Good morning. At the onset, I would like to thank Dr. Namrata ma'am and the scientific committee for inviting me here. It is indeed a privilege to speak about myopia, which is now a growing concern among children and also among adults. So I'll be talking about halting myopia progression with atropine. So I didn't do the epidemiology part because thinking Dr. Praveen Vashisht will be doing that part. So I'll be straight going to the progression of myopia. I think sir will speak later. So the annual rates of progression of myopia, we know that it is inevitable, and the rate of progression is 0.15 diopters to 1.2 diopters per year. And it is mostly seen in younger myopes, more myopia at onset, and due to ethnicity. So why do we fear myopia progression? Because we find that the risk of ocular pathology is mainly seen with high myopia. The risk of retinal detachment, we find that the odds ratio, when the higher the myopia, we find that if it is reaching up to -7 to -8, it is around 44.2% odds ratio. So this is not very good. So we need to halt the progression to at least, if we can halt the progression in children, not progress it beyond high myopia. So we have to counsel parents, because parents are still skeptical about putting any drops or wearing any glasses for the control of myopia, because they don't see the long-term risk. Like if you see a 4-year-old child with a -3 diopters, and if it is a 0.5 diopter increase per year, then we'll have -8. So at least we can keep it, at 14 years it is -8. So this is the progression which we still don't want, but this is what is inevitable sometimes. But if it is a 1 diopter increase per year, then we find that at 14 years, it may be -13 diopters. So this is what we have to counsel parents, because they think at the age of 4 years, 3 to hai, and then every year they come that, okay, 1 diopter increase. But we have to give them the long-term picture, why we are afraid of this myopia and why we want to tackle it early. So my topic is on atropine. So there are many methods of halting progression. Nowadays we have we have low-dose atropine, pharmacological method. Then we have the myopia control glasses, where many companies have come up. There are 3 companies which have come up with these glasses. We have orthokeratology, which again another speaker will be speaking on. And then we also have contact lenses. So we have for contact lenses for progression, for halting the progression. So I'll be speaking mainly on atropine. The exact mechanism is not known, but it is said to block the muscarinic receptors non-selectively. So it is believed that atropine acts directly or indirectly on the retinal or the scleral, inhibiting the thinning or the stretching of the scleral, and thereby the eye growth. So through the M1, M4 receptors in the retina, it is said to act not on via the accommodation system. So the ATOM studies were done, and this was published. So first in 2009, the atropine just for the treatment of childhood myopia. In this, the study done was just with 1% of atropine. Later on, they did another study, ATOM2 study, where they studied with the safety and efficacy of 0.5%, 0.1%, and 0.01%. In that study, the 0.01% was actually the placebo group. But what they found in the study was that all the 3 doses had the same response to progression, and that is how we found that that atropine 0.01% is as safe and as effective as atropine 1% with lesser side effects. And that is how, after the ATOM2 study, which has been done for 5 years, it is concluded that atropine 0.01% is effective in the treatment and in the halting the progression of myopia. So 0.01%, only 24% progressed in this study. The atropine, the safety also was, safety they studied was seeing whether the child had any problems. The pupil size was small, and also they found that did not have any blurring of vision. So let us go to different case scenarios, because what we want to know is that if in an 8-year-old child, if they're presenting you with myopia progression of 0.75, what is the treatment of choice, and what investigation should be done? Now the audience, I wanted some interaction from the audience. So basically, when a child comes with a progression of 0.75 and you want to give treatment, so there are three options now. What is the treatment of choice? So what we go is, first we find that what is the axial length. So we should do the axial length in all myopia children and find out it is progressive, whether it is the axial length only which is responsible for the progression. Because only the atropine 0.01% drops will have an effect only if it is due to the increase in axial length. So it is important for us to check the axial length. So this is the investigation which we need to do. RP Center group, and we had a childhood myopia group and workshop, and in the multi-centric randomized trial also, which was done in the Indian population, we found that atropine 0.01% worked, and will be the treatment of choice. So the next case scenario is the patient has been on atropine on LDA 0.01% since 1 year, and again it has progressed to 1.5 diopters. So now, how do we go ahead? Because the parents are complaining that again the progression has occurred. I have put atropine 0.01% for 1 year, and still there is progression. So then we can do combination therapy, like where we can offer the patients another modality of treatment is that we can give them low-dose atropine. Along with them, we can add a myopia control glasses, like Stellest or MyoSmart or Zeiss lenses, Zeiss glasses. These are available, and these are helping in halting the progression of myopia. Or we can even, if we find that, so what they studied was, which is the LAM study. I will explain in detail about the LAM study. So the proposed strategy in your clinic will be that you start on 0.01% atropine, and every 6 months you check the refraction and also the axial length. And then if there is a stable progress, you continue it for 2 years. And after, suppose now, if it is still progressing within 2 years also, then you can either switch to, with the LDA, you can switch to orthokeratology, or you can switch to, you can start with the myopia control glasses. And the next concentration which we'll be talking about is whether we can switch to the other concentration of atropine. And then if we find that we have continued it for 2 years, and then we stop it for 1 year, and then what happens after 1 year after stopping? If it is stable, then it is good. But if it's again progressing, then you can restart your atropine 0.01%, and you can give it up to adolescence. So you can give it up to the teen years, and you encourage your outdoor activities. You tell them that you need to do more outdoor activities, or you can also do combination therapy. So the combination therapy is working much more if the child is still progressing with low-dose atropine. So the LAM studies were done, phase 1, phase 2, and phase 3. And the LAM study, they studied 0.05%, 0.025%, and 0.01%. And now the third year is being completed, the phase 3, which they gave a report on 2022, they are published. And they found that 0.05% atropine remained the optimal concentration over 3 years in Chinese children. We were just discussing with Entod, who has sponsored this session, and they were saying that they are coming up with this dose of 0.05% very soon. And the LAM study has shown that this is more effective than 0.01%. So the side effects, but with 0.01% are very less, so we can give in all patients. I have just had 1 or 2 patients who have complained of blur vision, even with 0.01%, but that compared to the large number of children, we find that it is very less. So I will talk of the last case scenario. There is a 3-year-old wearing myopia glasses, single vision glasses, and it is -3 diopters. So, what is the next? Should we start on atropine eye drops in a 3-year-old, or we should not start? So we find that everybody is still starting on atropine eye drops. It is advisable that there are no studies being done in this age group for the atropine eye drops. We should not give in such children, observe, and we should just give the single vision glasses. So the scenario where we find that very high myopia is mainly with ROPs. We find that the parents are being advised to give atropine low dose, but remember that this ROP-associated high myopia is mainly because of lenticular causes. So, and atropine low dose is not going to have an effect on these children. So we have to know the cause and the effect. So for eyes with myopia, so we find that If it is not, it is because of the axial length elongation, then it is right to start on atropine low dose. But if it is because of the lenticular changes, please don't start atropine. It is not going to work. And also in very high myopia in infants, we find it is rare. It is less than 1%. So if you find a high myopia in very preschool children, say in less than 5 years, please investigate for the other causes. It is not common to see high myopia. So you may have to rule out if there's any Stickler syndrome. So it is better to evaluate them. It could be in a Down syndrome or other cases of retinal disorders. So please do an ERG, electrophysiological test, and also do a pediatrician and a geneticist involvement. So ocular image, electrophysiological test may be an additional thing when you see high myopia in very small children. I think this is the end. You can continue? Okay. So then the next scenario is a child, I'm just putting the cases because all these problems come to our practice, clinical day-to-day practice, and we don't know what to do. So now there is a child with a -6 diopters, and there is a squint also associated. There is an intermittent exotropia, distance and near 30 prism. So now what to do? Whether we should give atropine low dose or whether we should give the myopia control glasses. So myopia control glasses are not going to work in such children. So we need the low dose atropine will still work, and there are studies which have been done. And now there's a both situation where you have a high myopia, where you find that the demand of accommodation is more, and therefore the child may go into exo. And you can also have a child with exotropia, where the child has already problems with accommodation, and you can develop exotropia. So in both the cases scenarios, where you have to do is that, what should I do first? Whether I should control myopia or whether I should go for a exotropia surgery. It is ideal to go in for a exotropia surgery and then keep the child controlled on atropine drops, or you can put the child on myopia control glasses. So it is important that we control the exotropia. We can do surgery in these cases. And so, but you have to avoid atropine whenever it is because of any cone dystrophies, or if there's any potential cardiac complications or a syndromic myopia. So always try to evaluate the cause, and please don't start myopia, the atropine eye drops for any patient. So it is effective, but we have to see in which patients we need to start. Basically in age 4 to 12 years with documented progression of 0.5 diopters in the preceding year. And we can continue it for a longer period of time, though the atropine study has been only for 5 years, but we can continue. So basically we need to have good eye care habits, enhancement of time outdoors, and limiting near workload should not be also overlooked. Thank you.
Yes, sir.
Yes, sir.
Yes. So those we are not putting, yeah. I didn't do any study. I'm just saying that we should not include, we should look for these causes, the syndromic causes or the retinal dystrophies. We should look if. So we have to.
Genetic myopia, he want to say.
Yeah. So in genetic myopia, suppose if there is a genetic cause, and if the cause is because of an increase in axial length, you can still put atropine. But unless, suppose if there's a cardiac problem associated, like suppose if in a Marfan syndrome, then I would not put atropine. So you have to be careful.
Yes, Shukla sir.
Can I comment on? ऐसा है sir कि see, it's not only purely genetic. See, we have 200 genes. We are directly or indirectly associated with myopia. 26 genes have been marked, which are directly related to myopia. But it is not only the genetic. A lot of environmental factors are affecting. So, sir, pure genetic कुछ नहीं है अभी. No, there are so many things. बहुत सारी चीजें sir. There are so many things. Not. No, genetic is one of the causes. Triggering fact तो genetic है sir. That trigger. नहीं आप मेरा मतलब समझिए. You see, the triggering factor is genetic. I mean, it is genetic, but it has to be triggered by environmental factors. And there are so many environmental factors which have been now studied. There are almost 100 papers on that in the last 1 decade. Yeah, and sir, near work hai, continuous working hai, the length of work hai, you know, and your accommodation hai, you see, smoking bhi hai. There are so many things, you know.
As so we'll ask the delegate. See, why this discussion we are doing? atropine is very important in myopia. And nowadays, if you see, all the practitioners, when there is a myopia is seen, they are going for the atropine. So I want some delegates to ask their queries, and then we will discuss it in the, amongst the yes. Yeah, there.
I actually wanted to ask that most of the times what I am seeing is there is a child who has myopia. He has been seen by the doctor for the first time. They gave him the glasses and at the same time they start him on the atropine eye drops also. I mean, I'm seeing it very commonly. I mean, should we discourage this practice?
No.
What,
No, it is. See, I'm very much, affiliated with the myopia treatment. I'm the incoming president of the National Pediatric Society, and the entoured people we are doing in our annual conference of the pediatric ophthalmology. They are doing a full session, a 2-hour session of it. You see, you have to give glasses. See, one thing you should remember, that any child who develops myopia, what am I the reason? Because before 5 years is a progressive myopia. So you have to deal with it as a progressive myopia. And you have to give specs, otherwise, he can't see otherwise. If there is -4 or -3 in a 5-year child, how are you going to go to school? You see, so the basic is specs, there is no doubt about it. But then, the specs are not controlling the progression, specs are only as a palliative treatment. Specs sirf nazar ke liye hai. But what about the progression, how to suppress or how to curtail the progression of myopia? For that, we have now number of drugs, and so far, the atropine 0.01 and 0.05 have been found to be the most effective. Though we have pirenzepine, 7-methylxanthine, if in children 7-methylxanthine is very effective, more than atropine. So it's very safe in children. So, you have to compensate it with not only low dose atropine or pirenzepine like that, but also the environmental factors. You see, there is a big research, we don't have time, it has to be a full session for that.
This is not her question. Question is that when the patient comes to the clinic, patient is having the myopia, the first visit only they are starting the atropine. So they should start the atropine on the first visit, or they should see the progress, that the progress is 0.5, and because of that we are starting the atropine. So instead of starting the atropine to begin with, we should wait, see you can both axial length and also the increase in myopia. So Namrata, what is your this one in?
So I think Suma shall be able to answer this question, but
So
I think that if the axial length is increased, then how is atropine going to affect on it? I think that part the atropine cannot take care of.
So basically, what we are saying is that when the patient comes initially only, and with suppose with myopia, only when it is documented progression, say in the next visit, then we are starting. At least that's what we are practicing. We are not starting atropine in the first cohort. Okay?
How much should be the documented
So then
increase?
we have to, then
How
we will
much?
document. So that what the investigation, what we are going to do, we are going to document whether we'll do the axial length, we'll do, like suppose the pentacam also nowadays we are doing, so that we have the baseline what is there. And then we are seeing what is the progression. So next 6 months we'll call the patient again. And then if we see there is an increase in the axial length, and still we don't know whether it is, so like studies have not shown that it is atropine, like how Dr. Ma'am is saying, Dr. Namrata Sharma Ma'am, that whether it is directly affecting, but studies have shown that it is basically the atropine is affecting the axial length, halting the axial length progression only. It is not affecting on the accommodation part at all. So we can give it safely in children whose axial length is progressing. And when we have a documented axial length progression, then we should start atropine.
No,
To
the
add to
question
what
is
Dr. Lahane is
Suma.
saying,
Benchmark when we say this is progression and we have to
So when,
Yes. How
so
much
basically if
increase?
you are looking at anything more than 0.5 diopter
Yes.
increase in your refractive error per year, or a 0.3 millimeters of axial length per year, then we are looking at it.
No, we say every 6 months, not
No,
year.
every 6 months. But if the progression is showing, suppose in the 6 months it's remained stable, but when he comes back, so when you are documenting anything more than 0.5, nevertheless, if there is a parental history, there's a brother history, you see that the patient's lifestyle is he's a voracious reader, so you have to look at multiple things.
Yes.
But a documented thing is 0.5 per year and point. But we call them every 6 months. Every 6 months refraction is done. Every 6 months axial length is checked. So we know and we monitor this. That is important. But over and above whatever you're treating, lifestyle modification is extremely
Extremely
important, which means outdoor of minimum 2 hours. Reading, writing should be at 14 inches, follow the 20-20-20 rule, and whatever it is, take breaks. So this is something you have to keep on telling in addition to whatever treatment you give to them.
Basically, I think in the discussion, what is happening when patient is coming of myopia, we all are starting the atropine. So that should not be done. Minimum wait for 6 months, see the progression is 0.5, our axial length is increasing. It means myopia. Why we are doing this? Myopia is progressing or not. If it is progressing more, then only we will have to arrest it by the atropine. It is not only one drug, but other drugs can be there, but arrest. And about the percentage, she has already told us that this type of percentage we should give this 0.01 we are giving, 0.05 is better, that is lamb study, but it is not that entire would prepare it or manufacture it. But when patient is coming first time, don't give myopia. The second question to Suma, how many years we can give atropine?
So I've already mentioned, but I'll explain again. So basically, till now the ATOM study was done, and it was done for 5 years. No? So 5 years they have done the study, and even LAMP recent study they have done it for 3 years. So basically, you are giving, how we give is, we give it for 2 years, okay, then stop for 1 year. But in that 1 year, you are going to follow up the child every 6 months. So now if you find that when the child comes to you after 6 months, after you stop the atropine drop, again it has progressed, then you can continue the drop up to your teens. That is what the
Teens
recommendation.
is 18 years. You
18,
can
16 to 18 years, you can give it up to safely.
Very true. Now see, practically, the atropine should be started for 2 years. One, dictum. Stop it for 6 months. If progressing is there, again start. And then you can go up to the 18 years also. But always stop after 2 years and see, give the gap of 6 months and then go for the if required and progression is there, then you can start the atropine. And now